Electrolyte abnormalities can profoundly affect the cardiac conduction system, leading to distinct patterns on an ECG. These changes are often the first clinical sign of life-threatening abnormalities. Potassium is the most critical electrolyte regarding ECG changes because of its role in repolarization. As the levels rise, ECG typically progresses through these stages: mild hypokalemia, tall peak T waves, narrow base symmetrical; moderate hypokalemia, P waves flatten and eventually disappear, PR undeveloped longs; severe, QRS widens, merging with the T wave to form a sine wave pattern. This is a precursor to ventricular fibrillation or asystole. In hypokalemia, flattened T waves and ST depression can occur. Prominent U waves seen after the T waves, best in V2-E3. Prolonged QU interval, often mistaken for a long QT. And there is increased risk of tachyarrhythmias like toss at the point. Calcium primarily affects the duration of the ST segment rather than the morphology of the waves themselves. In hypercalcemia, there is shortened QT interval. The ST segment is nearly absent. The T wave begins almost immediately after the QRS complex. In severe cases, J waves may occasionally appear. Though Osborn described the wave named after him in hypothermia, there is also a view that all J waves can be called Osborn waves. In hypocalcemia, there is prolonged QT interval, specifically due to a lengthened ST segment. The T wave itself remains normal in shape, but is pushed farther away from the QRS. It can rarely predispose a patient to toss at the point. Magnesium abnormalities often coexist with potassium and calcium issues, as it is the cofactor for the enzyme transporting those ions in the kidney. Hypomagnesemia commonly presents with a prolonged QT interval and flattened T waves. Its most famous complication is toss at the point or polymorphic ventricular tachycardia. Hypermagnesemia is rare and usually seen in renal failure. It causes bradycardia, PR prolongation and QRS widening, eventually resembling hyperkalemia.